more folks who are logging on and calling in. So if you're having any trouble accessing the webinar audio or visual, please feel free to send me an email at shaw@astho.org. However, we do have a full agenda and some great presenters, so we are going to go ahead and get started. First, a couple of housekeeping things. Everybody is on mute, just out of respect for the presenters and the other folks on the line. So if you have a question, please feel free to type it in the chat box, and then we'll have a Q&A session at the end where you can either send questions through the chat box or press *7 to unmute your line. Also, following the webinar, we will send you a link so you can access the PowerPoint presentation and the webinar recording. Like I said, we have a full agenda full of experts from across the country and across many different areas of focus and membership. So it's a diverse group of experts, and we're really excited to hear from them today. And first, to start and provide a little bit of background on the motivation for today's webinar is it's supporting ASTHO's ongoing work with CDC's Healthy Aging Program, as well as an exciting initiative for this year, which is ASTHO's 2014-15 President's Challenge, Healthy Aging, Living Longer Better, and giving the burden of chronic disease and Alzheimer's disease and related dementias. The purpose of today's webinar is to highlight key data sources around these issues and discuss some of the strategies to use as data for action to promote the health of older adults. And as you can see from this slide, the 2014-2015 President's Challenge was developed by the current ASTHO president and Connecticut state health official, Dr. Jewel Mullen. And her call to action is to help older adults live and age well in their communities. And the President's Challenge is really informed by the Office of the Surgeon General's National Prevention Strategy and the strategic directions and priorities that are within that. And these, as you'll see and as you know, will touch on the topics that we're discussing today, such as Alzheimer's disease and related dementias and chronic conditions, and the many factors that influence those. And Dr. Mullen is asking her state health official colleagues to really increase the number of older adults living well in their communities through the implementation of evidence-based practices and through partnerships with new or enhanced partners and diverse groups across their state. And we, like I said, Dr. Mullen is calling on all of her colleagues to sign on to this pledge and implement a strategic direction or priority around promoting the health of older adults. And so far, 30 states and 2 territories with really associated states have committed to supporting the 2014-2015 President's Challenge. And we have until the end of September, so we're hoping to have the whole country colored in purple by the end of September. And of course, we understand that into tying all of this to today's webinar and the goals of today's webinar is we understand that any action to promote the health of older adults must be informed by accurate data, and that it's important to know which areas to focus on, in what community, and among which population. So today's presentations from experts across the country will touch on a few of these data sources and how those interested in promoting the health of older adults can use them for action. So I will now turn it over to our first presenter, Dr. Linda Anderson, who is with CDC's Healthy Aging Program.
Thank you, Lynn. Can you hear me?
Yes, I can. Thank you.
Thank you. On behalf of the Healthy Aging Program, I'm very appreciative of the continued partnership and support from ASTHO on this webinar series and in many other areas. What I'm going to do this afternoon is to provide a very brief overview of 3 issues. One, to draw your attention to multiple chronic conditions and the work that's been going on. I want to introduce you to the Healthy Brain Initiative Roadmap in case you are not familiar with that. And then to dive a little bit deeper into one area, the monitor and evaluate, the work that CDC is working on with the BRFSS, the Behavioral Risk Factor Surveillance System, which will be touched upon by other presenters more in detail. So I hope you're all familiar with the multiple chronic conditions, a strategic framework which comes out of the Office of the Assistant Secretary for Health and started in 2010. These are the 4 major goals, and one important goal is to facilitate research to fulfill knowledge gaps. And on the next slide, we'll see an important statistic that has really come out of the Centers for Medicaid Services in looking at the number of chronic conditions and then the distribution of spending for Medicare beneficiaries in 2010. And if they looked at 15 chronic conditions, which were available from the CMS Chronic Conditions Warehouse, an important data set to understand and be familiar with, and this includes Alzheimer's disease. And the basic take-home message is that on the left side is you will see the percent of beneficiaries with multiple chronic conditions, and over 2/3 of beneficiaries have 2 or more chronic conditions. You'll see the percent of total Medicare spending, and you'll note that those with 6 or more conditions account for nearly 50% of spending related to Medicare. And I just wanted to bring to your attention that CMS has developed a number of tools, including the dashboard that will be talked about a little bit more in depth later, but really looks at the cost by state and national levels and provides a number of maps, charts, and a comparison to national data. And then I wanted to introduce you or to familiarize yourself with the Healthy Brain Initiative. This came out in 2013. This was a second in a series of roadmaps that were done in partnership with the Alzheimer's Association, and you'll be hearing from Mr. Baumgart in a few minutes about some more of that work. But this was used and developed as part of a participatory process that resulted in 35 actions the public health community, in partnership with aging services and other networks, can do over the next 5 years to really promote cognitive function, to address cognitive impairment for individuals living in the community, as well as help meet the needs of care partners, and this includes both professionals as well as families. And there are 4 domains or areas in the roadmap that these action items address. One is educate and empower the nation, develop policy and mobilize partnerships, assure a competent workforce, and really the focus of this webinar is monitor and evaluate. And I've given 2 examples of actions that relate to what we're talking about today. And one of those is implement the behavioral risk factor surveillance system's cognitive impairment and caregiver modules. And then another action is to conduct a review of the literature on co-occurring chronic conditions and dementia, including Alzheimer's disease, to understand the effect of dementia on various outcomes such as depression, disease management, morbidity, and mortality. And these reports are coming out and being released. This work has been ongoing for several years. And really the area of cognition for CDC provides many opportunities. One, I think you'll all realize there's tremendous visibility in Alzheimer's disease and related dementias, really at the national level and increasing in the state and local levels. Cognitive health and impairment is a relatively new area for public health, but one that we really are embracing and really want to see the integration of this important issue along with physical health. And then really the prevention intervention scientist, is building and growing. And there's a new IOM report on cognitive aging that has come out that's talked about the importance of physical health, the importance of controlling cardiovascular as well as medications. And so really the piece we're focusing on today is we're beginning to build data and resources from which states and communities can draw upon. And one of those actions, as I've mentioned, is implementing the behavioral risk factor surveillance system's cognitive impairment and caregiver modules. For those of you who are quite familiar, I hope, with the behavioral risk factor surveillance system, it's the largest continuously conducted telephone state-based health survey in the world There are over 400,000 telephone interviews conducted among community-dwelling adults aged 18 and over each year. And the states use this data to establish priorities, plan, tailor policies and programs, and track progress over time. And you'll be hearing more about that. And CDC is pleased to support those two modules. And we have developed a number of ways to use the module. And I'll point out we have 3 recent publications, which are all listed on this slide. It's an open access journal, Preventing Chronic Disease, that talks about both from an individual perspective, from a household perspective, as well as from proxies. And then we have several reports that focus on data at the state level for those states that have used the cognitive decline module and questions on increased confusion and memory loss, and one of those focuses on chronic disease. And the last thing I wanted to point out was we also have put this data on our online Healthy Aging data portfolio, and I have listed there the website for you to be able to access that. We're now moving to an open data portal, and so our data in 2015 and beyond will be accessible to all, and people will be able to actually do analysis on that as well as get the summary data. So in closing for my presentation, I wanted to provide you some links for how to access this information, and we're really delighted to be a participate in this session today. And with that, I'll turn it over to Matthew Baumgart.
Thank you very much, Linda, and hello, everybody. I'm Matthew Baumgart. Since you can't watch me, I thought I'd put a picture of myself so you can see how really good looking I am and how much you're missing by not seeing me in person. I'm the Senior Director of Public Policy for the Alzheimer's Association, and I also am the Project Director for our cooperative agreement with the CDC on the Healthy Brain Initiative. And one of our big efforts since 2010 has been on the BRFSS cognitive module. And over a 3-year period for the 2011 through 2013 surveys, we worked and provided financial support through our cooperative agreement with the CDC to get states to use the new cognitive module. It was pilot tested in 5 states in 2009, and so the 2011 survey was really the first widespread use of the cognitive module. And you can see on the screen that over the 3-year period, we were successful in getting 45 states, the District of Columbia and Puerto Rico, so 47 out of our 52 target in using the module. And this was a great success. We were very, very pleased with the support that we received from states and the BRFS coordinators in wanting to use this module. In fact, the BRFS cognitive module was the most rapidly adopted module outside of the core in the BRFS history. I thought it was helpful, before I talk to you about some of the ways that the data has been used, to just talk about why the data is important, why it's important to conduct this survey with the BRFS, with the cognitive module. So we know from a variety of sources that Alzheimer's disease is a huge and growing problem, and the Alzheimer's Association documents that every year in its annual Facts and Figures report, as well as in additional publications such as the economic report that we released in early February. But in general, there's a lack of state-level data. We do have state-by-state prevalence estimates, and we do have some state-by-state data on caregiving, but it's very high-level numbers. And while the state prevalence estimates for Alzheimer's disease do include projections of prevalence out 10 years in the future in 2025, it's a prevalence estimate that while you can infer the burden in general, it's really not addressing a specific burden or specific needs and impact. And it's estimates. It's not a snapshot of what I call the actual pipeline. But the BRFS gives us that, because by asking the question about increased confusion or memory loss, what we refer to as ICML, it's really showing us what the future potential problem might be. There's a growing body of literature. The scientists and researchers call it subjective cognitive decline. There's a growing body of literature that shows that this is actually a good predictor of future Alzheimer's and dementia. And so by looking at people who are beginning to have increased confusion or memory problems, we have a snapshot of the potential future problem of Alzheimer's and dementia. And we also have a beginning of an understanding of some of the impact and burden that those individuals face. And you can get that individual snapshot on burden and impact at the state level, and the specific needs of the state may vary, and that's one of the great things you get by using the module. And I put 3 examples up here. These may not be, when you look at individual state data, what everyone will necessarily pull out, but this is when I was looking at these 3 states' data, things that popped out at me. And I'll just mention, for example, Hawaii. If I was in Hawaii, I would look at the BRFS data and see that of those who are having increased confusion or memory loss, almost 90% of them have not talked to a healthcare provider about their increasing memory problems. And I see that of those with ICML, more than a third of them are having functional difficulties related to the memory problems. It's interfering with activities of daily living, or it's or their ability to work. And so that might point to some specific issues that need to be addressed in our particular state, in this case it being Hawaii. And so that really gets to the saying that we have employed since the beginning of this effort at the Alzheimer's Association, and that is, data is only useful if it's used. We have made a commitment that not only will we be asking states to collect this data and supporting states in collection of the data, but we will make sure that the data is used, because data sitting on a shelf doesn't serve any purpose whatsoever. And so we have produced individual state fact sheets, state data tables. There's a portion of our website that's devoted to the data collection efforts on both the cognitive and caregiver module on our alz.org website. And then on the lower left-hand side, you can see a snapshot of us, of a document that we created that connects some of the data from the BRFS cognitive module to various actions in the roadmap that Linda talked about a few minutes ago. Dissemination of the data is the first priority. That's not exactly about using the data per se, but we found that dissemination of the data itself is very, very important. It starts to embed the idea of cognitive health and cognitive issues into the thinking and into the conversations. And the state of Utah is a really good example of this. The state of Utah collected the BRFS cognitive data in 2011. That data was released by the CDC in May of 2013. And our chapter in Utah worked with the state public health department to do some media outreach on the data. Our the chapter executive of our chapter told his entire staff to embed and use this data in all activities of the chapter, from educational conferences to support groups to programs. And it just became a way of changing the thinking and jump-starting the conversation, such that at the time, the relatively stalled Alzheimer's disease plan has now started to gain some momentum in terms of implementing that plan, because there's a greater understanding and a greater thinking of this issue. It's much more part of the conversation, and in fact, the legislature in Utah just recently approved a $161,000 appropriation to implement the state plan. And the word from on the ground is that the state health department may very well use that to hire a dedicated individual to focus solely on Alzheimer's disease. Again, that was not an example of how the data specifically were used. That was more about how the dissemination and the general conversation around the data can change the conversation. But I do want to mention and highlight a few examples of specifically how the data was used. So I'll start in Georgia. So shortly after the data was released in Georgia, the Alzheimer's Association chapter, as well as several other individuals with the state government in Georgia, State Senator Renee Unterman, who's on the right side of that picture there, we participants from the Department of Health and the Division on Aging Services, as well as several individuals from the broader healthcare community in Georgia, gathered in the state capitol to hold a press conference on the release of the data. And the data were used to illustrate the importance of developing a state Alzheimer's disease plan. State Senator Renee Unterman had sponsored that legislation in the state legislature, and the state plan task force, the group charged with writing the state plan, was preparing to meet for the first time. They had not met yet. They were preparing to meet for the first time, and this data really galvanized the effort to develop the state plan in Georgia, and it really helped throughout the process until the plan was released in 2014. It really helped guide the development of Georgia's state plan, and really made it more of an informed state plan that would address needs that were highlighted by the data from the cognitive module, the BRFSS. But it's not just about the association using the data, and it's not just about Alzheimer's specific uses of the data. So in Missouri, an attempt had begun prior to the release of the data to create a movement, a campaign called the Seniors Count Initiative. But it was really the BRFS data that helped galvanize the effort. You can see on the screen some of the organizations that are part of this initiative. And this, again, is broader than Alzheimer's disease. It's focused on increasing services for seniors at the local level. And by having the BRFS data on what's happening on cognition and on cognitive decline in Missouri, it really helped build that effort. Another example is West Virginia. West Virginia, the data in from the 2011 survey showed that, and the 2012 survey, they collected the data in both years, showed that over a third of the people who are having increased confusion or memory loss live alone. Over 60% of them had had a fall within the previous 12 months. And so the West Virginia Partnership for Elder Living looked at this data and said, we need to develop an ongoing task force to assess and plan for housing needs of seniors in West Virginia. And that task force is ongoing, and it provides policy recommendations on the needs of senior housing. The last example I'll mention today is New York. There is a picture of David Hoffman, who is the director of the Bureau of Community Integration and Alzheimer's Disease for the state of New York. At the time, that picture was taken in the state capitol in 2013 when the BRFSS data were being released. At the time, he was the Bureau Director of the Office of Health Insurance Programs, and the focus of the data really helped galvanize a couple of efforts in New York. One is that the Department of Public Health in New York sent a letter to all healthcare providers, all doctors in the state, telling them about the importance of early detection and diagnosis and validated cognitive assessment tools. And then in 2014, Dave's position changed, and so he now has a title that includes Alzheimer's disease. There's dedicated staff to Alzheimer's. In fact, one of those staff members is actually housed in our Albany chapter's office. And then this year, just very recently, the legislature passed and the governor signed a 2-year, $50 million appropriation to increase respite care services for caregivers, to expand quality assurance programs, to reach traditionally underserved communities, and to enhance dementia education for healthcare professionals. And that all began really 2 years ago with the release and dissemination of the BRFSS cognitive data. Our goal in 2015-2016 is to have all states again use the cognitive module, but to also use the caregiver module. There you can see the current commitments, 38 states on the cognitive module, 29 on the caregiver module. If your state is not purple, if it's white, there has not been a commitment. We have some funding through our cooperative agreement with the CDC available, and you can contact Molly French to find out more information on that. There's, again, is Molly's contact information. My contact information is at the bottom, and a couple of websites for further information, not only on the BRFSS data, but on Alzheimer's disease in general, and Alzheimer's as a public health issue in general, are on the screen. And with that, I believe next up, I will turn it over to Renee.
Hi, thank you, Matthew. My name is Renee Callanan. I'm a CDC state assignee and chronic disease and oral health epidemiologist at the Colorado Department of Public Health and Environment. And for this webinar, I'm representing the Council of State and Territorial Epidemiologists, or CSTE, as the Chronic Disease, Maternal and Child Health, and Oral Health Steering Committee Chairperson. Thank you for advancing the slide. I'd like to start out by thinking about why we care about data. Public health surveillance is a set of processes to help accomplish at least one of the 10 essential public health services. That is, monitoring health status to identify and solve community health problems. Surveillance involves everything from planning and data collection to the application of information to public health programs. Surveillance data can help to demonstrate the need for public health programs and resources, inform resource allocation, monitor effectiveness, and identify high-risk populations. Another way of thinking about the use of data is within the evidence-based public health framework. An evidence-based public health approach combines the best available data, research, practitioner expertise, and community preferences to inform all the stages of program planning, implementation, and evaluation in order to improve population health. Using an evidence-based approach provides you a collaborative yet systematic process that leads to data-driven, effective strategies for implementation. CDC's website on health information for older adults illustrates the breadth of health-related issues that older adults are faced with and how it is truly a cross-cutting issue, from Alzheimer's disease to influenza to oral health, obesity and physical inactivity to advanced care planning. Now I'm going to quickly highlight several data sources and resources related to older adult health. The webinar slides will be available for your future reference. This list, though certainly not completely comprehensive, shows many important data sources related to older adult health. These data sources can be used during the community health assessment and quantification of the health issue phases of evidence-based public health approach. The Behavioral Risk Factor Surveillance System, or BRFSS, is one source that has a wide variety of population-based prevalence data available for all states. This list shows most of the major topics for which older adult health-related data are available from BRFSS. Data can be accessed for the total adult population or by demographic factors such as age. With the possible exception of those BRFSS state-added modules, data are available on these topics annually or every other year, depending on the topic. Utilizing 2010 BRFSS data, the State of Aging and Health in America 2013 report by CDC presents a snapshot of the health and well-being of behaviors that contribute to premature death and disability for older adults nationally. There's a national report card and state-by-state report cards that report on 15 indicators of older adult health, 8 of which are identified in Healthy People 2020. Also included in the report are several calls to action intended to encourage individuals, professionals, and communities to take specific steps to improve the health and well-being of older adults. Older Americans 2012 by the Federal Interagency Forum on Aging-Related Statistics presents national data on the well-being of the U.S. population aged 65 years and older in a non-technical format. The report includes 37 indicators that are grouped into 5 sections: population, economics, health status, health risks and behaviors, and healthcare. There's also a special feature on end-of-life issues. The National Chronic Disease Indicators were recently revised through a consensus process among a work group with representation by CDC, CSTE, and NACDD, which is the National Association of Chronic Disease Directors. The results are presented in a comprehensive MMWR report. There are now 124 indicators in 18 topic groups. The new topic areas in the revised set of indicators include disability, mental health, older adults, and then reproductive health and school health as well. The revised indicator set has a new, enhanced, and interactive website, which includes visualizations such as charts, graphs, and maps. A complementary data portal provides more in-depth analysis options. The data portal also contains data from CDC's Office on Smoking and Health, Division of Reproductive Health, and Division of Oral Health. This table shows the 4 new older adult indicators included in the chronic disease indicators. Topics for these include hospitalization for hip fracture, osteoporosis screening among female Medicare beneficiaries, concordance with clinical preventive services, and prevalence of multiple chronic conditions among Medicare beneficiaries. Data on these and many other related indicators are available on the website. The additional related indicators include hospitalization for COPD, disability, influenza and pneumococcal vaccination, and lost teeth among adults aged 65 years and older. The website is designed similarly to the Healthy Aging Data portfolio that Linda presented earlier today. You can select to view all indicators for one location, so for example, all indicators for Utah, or one indicator for all locations, such as tooth loss in all states and territories. This is a screenshot of the report for all indicators for one location. For each indicator, there's a bar chart that shows the estimate for your state or territory and the estimate for the United States overall, if available. This is a screenshot of one indicator for all locations, and this is the map view. And this is how the same data are presented in chart view. I like how you can compare across states and to the U.S. in this view while examining the uncertainty in the estimates. You can see that confidence intervals are provided on the bars. And finally, the comparison report allows you to select up to 12 states, territories, or large health departments to compare on all indicators. A table of results shows both crude and age-adjusted estimates as appropriate. The CDI website has a large quantity of data available in numerous types of formatting, and data are updated in a timely manner. Another report I'd like to highlight is America's Health Rankings Senior Report by United Healthcare Foundation. It provides state-level data on numerous indicators and compares the state's estimates with all other states. This map shows states' rankings on an overall senior health index. Available state summary products in PDF format include an overall state one-page report with data on several indicators and a summary highlighting key results. This is Arkansas's report. You can get an infographic highlighting a few key indicators for your state. And there's a summary of disparities by race, ethnicity, where data are available. Note that this report has many different indicators, both for all individuals and by race ethnicity, than the overall state report. You can also compare one state to the nation or another state. This screenshot shows Arkansas compared to Mississippi. Examples of ways to take action to address the issues are also provided in this view on the website. The CMS Chronic Conditions Dashboard was previously discussed today, but I would like to reiterate the importance of multiple chronic conditions to older adult health, as well as how the dashboard contains a plethora of data. The CMS website has state data on the prevalence of individual chronic conditions, multiple chronic conditions, specific combinations of chronic conditions, and utilization and spending for Medicare fee-for-service beneficiaries. Other data websites with state or county level data include CDC's Healthy Aging Data Portfolio, the Chronic Disease Cost Calculator, CDC's Community Health Status Indicators, which have been recently updated, the American Community Survey, CDC's Web-Based Injury Statistics Query and Reporting System, or WHISKERS, and CDC's Oral Health Data Applications. And this is just a list of other healthy aging reports and resources for your reference. And I'd like to just end with a slide about the Council of State and Territorial Epidemiologists. Even though older adult health is a cross-cutting issue, I'm going to focus on some activities, resources, and reports from the Chronic Disease, Maternal and Child Health, and Oral Health Steering Committee. This steering committee has been involved in several capacity building activities. We recently disseminated an epidemiology capacity assessment which includes recommendations for states to build capacity in this area. We are very excited to release our Chronic Disease Epidemiologist Orientation Manual very soon. And this will be a great resource for all types of applied epidemiologists. We have offered peer-to-peer consultations to jurisdictions. States can apply to be a host site for applied epidemiology fellows. And our committee and others offer many great webinars and trainings throughout the year. An example is the Program Evaluation Webinar Training Series that's currently happening. And of course, the SDE is the home organization for applied epidemiologists and offers opportunities for networking and communications, especially within our subcommittees and work groups. I'll be happy to take any questions at the end, but I think it will be time for our next presenter, who is Francis Anor.
Thank you, Renee. This is Francis, and currently I am the Alzheimer's disease epidemiologist for Georgia. So I'm going to base my presentation on what the previous presenters actually first said, particularly Matt. So currently, based on the Alzheimer's Association estimate, we do have about 130,000 adult Georgians that are living with Alzheimer's disease, and we are expecting to have even an increase by 2025. And Georgia happens to be one of these states that will have over 40% increase in Alzheimer's disease prevalence between 2050 and 2025. So within 10 years, we are increase in prevalence is going to exceed 40%. So based on that, from the publicly available Medicare data, we have about 93,200 Georgia Medicare beneficiaries that have diagnosis of Alzheimer's disease or related dementia. And so that represents about 72% of the estimated 130,000 adult Georgians who have Alzheimer's disease and related dementia in Georgia. And in 2012, we observed about 13% of those 93,200 who were hospitalized for other conditions, not necessarily because of Alzheimer's disease, but for other conditions. And that cost total charges was about $467.2 to Medicare in Georgia. And in Georgia, we had about close to about 3,700 Alzheimer's disease and related dementia patients that passed in 2012. So with these issues going on, what we don't know here in Georgia is the exact number of people that do have this condition and the distribution that will guide our effort to direct resources to address the future needs. So as Matt said, so in 2013, there was this formation of the Georgia Alzheimer Disease and Related Dementia State Plan Task Force that worked very tirelessly, including the Alzheimer's Association, to come up with a state plan. And based on the state plan, one of the recommendations was to create a registry, which gathered a lot of momentum. So in 2014, there was a bill that passed that gave some power to the Georgia Department of Public Health to create a registry in Georgia. Now, since this bill passed, we have been working in the past 8 months to try to establish this registry. And this chart you see here represents the data sources that were available at the time, those we were pursuing, and how we are going to create this registry. So currently, we have been able to roll out a portal where physicians are able to report to the state if they diagnose anyone with Alzheimer's disease or related dementia. Currently, we also have other data sources, including the hospital discharge data, emergency room visit data, as well as vital records. We are pursuing other data sources which are highlighted in yellow here, including our state benefit plan, Georgia State Health Benefit Plan. We also are pursuing data from Medicare, Medicaid, as well as our Georgia Regent Health Plan, which is the health plan for university systems of Georgia. And at the end of the day, we are trying to have all these data sources. We will create an algorithm that will be able to deduplicate all these information we are receiving and be able to link them and create this data in the registry, which will be analyzed. And we also anticipate researchers also requesting for some level of data, de-identified data that they can also use for research purposes. So currently, we do have multiple sources of data, and one of the things that I'm going to highlight based on what previous presenters gave is the BRFSS, and I'm going to talk about two main things that we see here in Georgia from the cognitive impairment module, and we have other data sources, as you can see here, including the Medicaid and Medicare. So using the 2013 module, we here looked at among the 45 years and older, the prevalence of increased confusion or memory loss using the module that Matt mentioned. And we found about 12.2% of adult Georgians 18 years and older who reported experiencing increased confusion or memory loss in the past 12 months. And that is about almost 400,000 adult Georgians in this 12.2%. And what we see here in Georgia is that we do see differences. So this reporting of increased confusion or memory loss is not evenly distributed. We do see some differences by demographic characteristics, socioeconomic status, as well as some chronic diseases. And one thing I just want to highlight, you will see a bunch of charts, but there are two main takeaways from these charts that I'm going to present. In Georgia, for the 2013 data, we didn't see much significant differences by somebody reporting increased confusion or memory loss by age, going from 45 years and older, or by race or sex. But we do see significant difference by socioeconomic status as well as by chronic disease condition. So as you can see here, even though you see high prevalence among 55 to 64, being the highest, but it wasn't statistically significantly different from any of these, as you can see from the 95% confidence intervals represented here by the standard bars, the error bars here. Now, when it comes to the socioeconomic status, we do see those differences, and those red bars represent situations where we have significant difference of the prevalence by certain group than the others. So you can see here that adults that reported making under $35,000, the prevalence of ICML was significantly higher compared to those making between $35,000 to $50,000, as well as $50,000 and over. And you can also see the same thing for education. The only difference here was those with some college education, as well as compared to those with who are college graduates. Those with college graduate college certificate were significantly has significant lower prevalence of ICML than those with some college. We also see that from two questions from the social context module, which was asking about ability to be able to pay rent or to afford food, and that also represents some level of socioeconomic status. And among those that reported that they always or usually or sometimes have difficulty paying rent, you have about 20.5% prevalence of ICML among those compared to those who reported rarely or never having this difficulty. And you can also see the same thing for the ability to afford food. You also have 24.8% prevalence among those that reported usually, always, or sometimes compared to only 8.1% among those that reported rarely or never. And these two numbers were significantly different. By chronic disease risk factors, we also see smoking. Those who smoked or who were current smokers had significantly higher prevalence of the ICML compared to those who are non-smokers. We didn't see statistically significant difference by weight status, even though you can see here 14.2% and 11.4% for those that were not obese. Now, by selected chronic conditions, we looked at this from about 3 different perspectives, and one of them is looking at the general health status, people's perception about their health. So we group that into the BRFSS suggested groupings, which is excellent, very good, or good, as one group, as well as the fair or poor. And you can see a significant difference in terms of the prevalence of ICML by these two categories, 27.3% among those who reported their health to be fair or poor, compared to just 7.3% for those that reported their health to be excellent, very good, or good. And you see the same thing for mental health status, 43.5% prevalence of ICML among those that reported that in the past 30 days, their mental health wasn't good on 40 or more days. So about half of the months, they didn't experience good mental health, and you have about 43.5% prevalence of ICML among those groups. Finally, we're also looking at some specific chronic conditions, and we selected two here, and because of time, but you see arthritis and cardiovascular diseases. And CVD here refers to both if any person has been diagnosed with one of these three conditions, which includes stroke, angina, or heart attack. So for arthritis, you can see about almost 20%. We have prevalence of ICML of about 19.6% among those who have been diagnosed with arthritis, compared to 7.3% among those who have not been diagnosed with arthritis. You also have similar trend when it comes to cardiovascular disease diagnosis, which is almost 25% compared to about 11% for those that have not been diagnosed in terms of prevalence of ICML. So this is what we are doing here in Georgia, using both the BRFSS and currently the other data sources, and hopefully our data from our registry is also going to boost in terms of to be able to identify where the needs are and to be able to direct resources across the state to address Alzheimer's disease and related dementia in Georgia. I'll be happy to take any questions. I think I'm done.
Great. Thank you so much, Francis, and to all of our presenters. Please feel free now to ask any questions through the chat box, or you can press *7 to unmute your line. Just let the presenter know, whoever it is you're asking your question of. Please just go ahead and ask any questions through the chat box or through the phone line. And also there will be an evaluation following today's webinar, so please respond to that as well. But are there any questions from the group? Okay, well, hearing none, this is certainly not the last opportunity to ask questions of any of the presenters today or me. Please feel free to send me an email and I can direct it to the right person. Also, like I said, we'll be sending the PowerPoint presentation and the recording following today's presentation, so you'll have everybody's contact information and presentation slides then as well. So unless anybody has anything else, I just want to thank again all of our presenters this afternoon, and we really appreciate everybody presenting and attending. So thank you very much, and have a wonderful afternoon.
Thank you.
Thank you.
Thank you. Please stand by.